running time so that we can deal with all of the issues around this particular subject. Our goal with these dialogues, as with every dialogue, is to provide you, the journalists, with news you can use in serving your audiences. Monkeypox is grabbing headlines around the world and in the ESA region, and we want to make sure you get the answers you need in order to inform your readers, viewers, and listeners. So please feel free to type your questions in the Zoom chat box during this dialogue, and we will do everything we can to make sure that those questions are asked of our speakers today. I'd like to start today with showing a video from Viral Facts. Viral Facts Africa works with fact checkers and health experts across Africa to debunk misleading health claims. It is the public face of the WHO's Africa Infodemic Response Alliance, a network of trusted public health institutions and fact checkers working to make scientific, fact-based health information highly visual, vibrant, and shareable on social media. We have a very new video from Viral Facts to start off, dealing with monkeypox, and let's have a look at that right now. Great, thank you. Okay, so our first speaker, we get to welcome back a friend of Media Dialogues, Dr. Otim Patrick Kosiramada. He's Health Emergency Officer with the Emergency Preparedness and Response Cluster at the World Health Organization in Brazzaville. Dr. Ramadan will brief us on what we need to know about monkeypox. Dr. Ramadan, welcome back. Thank you. The floor is yours.
Thank you very much, Wayne, and good afternoon, colleagues. It's good to have you. I think we have a very important topic today, and we look forward to having a very fruitful discussion. So as Wayne has rightly introduced, I work with the WHO Emergency Response Program, but my background, I am a medical doctor with specialization in epidemiology, and I've been, I think, at the forefront of a number of public health events on the continent over the last few years. So I'm happy to be here. I can ask the colleagues to put the slides up, or I share from my side. Thank you, Christoph. Thank you very much. So, colleagues, we are dealing with monkeypox, and we would like to discuss a few issues about monkeypox, the status in our region as well, and some of the messages that we would like you to carry forward to the general population. So, next slide, please. I think I would like to start from there. I saw already a number of questions coming in the chat. Where did monkeypox come from? So the word monkeypox, like some of our colleagues like to say, is really a little bit of a misnomer, but that's the name we have to deal with for now until if there's going to be a change in the name. But monkeypox is a viral zoonotic disease. We call it zoonotic because it originates from animals, and then it can be transmitted from animals to humans. It's not a new virus as such. The virus has been around. It was first isolated in animals in the 1950s, but the first documented human case was in 1970. So the virus has been there, and largely it has been in Africa, mostly in the tropical rainforest in areas in the Central Africa and in the West, in the Western Africa. And it is characterized by fever and rash, and has a range of illness. It can range from a mild asymptomatic disease to a very severe one where we have unfortunate deaths have been recorded. Next slide, please. So for monkeypox, we are looking at two scenarios of transmission. We have what we call the primary infection. And the primary infection arises mostly when we have the interaction between humans and animals. And there are a number of animals that have been identified, both animals that stay within the rodents, but also some of the wild animals that have been identified to be reservoirs of the virus. And contact with these infected animals or contact with contaminated animal products results in your initial case, which we are calling the primary infection. Now, the person, the gentleman you're seeing in the middle, once he develops the symptoms, he's now infectious and he's able to infect other humans. Now we move on to the secondary infection, which is the human-to-human transmission now. And this one primarily occurs in the context of contact, close contact with a person who is sick, especially when the rashes are there and there's the fluid coming from the rash, or contact with body fluids of this person who is infectious. That results in the secondary transmission. Now, the more a person who is sick with monkeypox has contact with several other people, it amplifies this transmission and we get many other people getting infected. There are, of course, other instances of few documented of mother to fetus transmission, but the context of transmission is largely contact. And this contact can be in different types of social settings where contact happen. And we human beings, we are very highly, tactile beings. We like to touch and to get in contact with each other, and a lot of exchange then happens in that context. So next slide, please. So we have an array. When you look at monkeypox, we have a disease with an incubation period of 15 to 21 days. And commonly the mean is around 16 days. And during this incubation period, the person has no symptoms. So virtually the person has been exposed, could have picked the virus, but they don't have any symptoms. And then the febrile stage now is usually the indication that the person is now starting what we call the prodromal phase, or the febrile phase. The person starts with high fever. And then in this phase, which lasts between 1 to 4 days, you can have fever, swelling of the lymph nodes, usually around the neck, and also in the armpits, what we call the axilla. And then you have headache, chills, sore throat, malaise, and fatigue. So this phase, usually in our setting, is very difficult to differentiate because we have a number of clinical conditions, malaria, typhoid, all these others that present with this, except with the swelling of the lymph nodes, which is not very, very common, but it does occur with a number of things. Even infections do cause this. Now, the next stage is the rash stage. And you have the rash now occurring, and the rash usually starts from the mouth and the face, and then spreads to the rest of the body. There are so many other viruses that we deal with also that cause rash. But the rash of the monkeypox is that one of the defining things is that you get rashes also on the soles of the feet and on the palm of the hand, which is not common with the other types of the viruses. And so this rash stage is the most infectious phase. And the rashes typically move, we have different names for them, but usually you have a raised flat swelling, and then thereafter it fills with fluids, what we call a vesicle, and then after it forms a pus, what we call a pustule, and then the pus starts breaking and the fluid coming out, and that fluid is very, very infectious, and that contains a lot of virus, and after that, the person goes on to heal and recover. So this phase can take up to 2 to 4 weeks, the person is in that phase. And then thereafter, they recover. So this is what happens when a person has monkeypox. If we can go on to the next slide, I would then like to highlight something that one of the colleagues raised. So in Africa, we are seeing typically 2 distinct patterns of transmission. The first one is what we have had before, where we have sporadic transmission in remote areas, remote communities. And this is usually because you have spillover from the wild or other rodents and organic and animals that move, that come in contact with the different communities or things that people hunt for food. Then you have this initial transmission being triggered. And this is being seen in Cameroon, in Congo, in Central Africa Republic, and in DRC. The next then is what we have been seeing in terms of the slow person-to-person transmission, mostly in the rural peri-urban areas. And we have seen this for a long time, mostly in Nigeria and Ghana. And what we are now trying to see is that we want to understand better what is driving this slow human-to-human transmission. And we have planned then that there should be proper epidemiological investigations to be able to tease out some of the drivers and factors behind this pattern of transmission. Next slide, please. So someone posted in the questions, should we be worried about monkeypox? Yes, we should. And apart from the rashes that we have mentioned, monkeypox results in infection of the glassy part of your eye, what we call the cornea, which is very, very important for vision. So you have corneal infection, and that can result in loss of vision, as you're seeing in this picture. But there are also secondary bacterial infection. You have the whole body of the person being exposed in terms of wounds. So bacteria can enter in, and this person gets infected. You have abscess that can form and airway obstruction up in the airway. You have pneumonia from bacterial infection. You have infection of the blood, what we call sepsis resulting septicemia. We have also heard of now of deaths from inflammation of the brain, what we call encephalitis. In pregnant women, it causes miscarriage. And of course, we have seen deaths globally now, 12 deaths and 7 of them being in Africa. So we have serious complications that arises from monkeypox infection. And that is why we really, really need to be concerned. Next slide. So what is the global situation then of monkeypox? So as of 15th, we are looking at over 35,000 cases globally. The WHO regions are showing in the different colors, but the common, the most affected now is the European region. And then we have the region of South America, and then the African region is number 3. One thing you have to notice then that all these 19,000 and 15,000 cases you are seeing are just cases resulting from introduction or imported transmission that has happened very recently. So this is just from the beginning of year up to now. Next slide, please. So coming to Africa. And so from January up to now, we have seen 405 confirmed cases. That's this year, and 7 deaths from 11 countries. From these 11 countries, 6 are countries that have previously been reporting or have previously detected monkeypox. In the last week alone, we have had 27 cases with 0 deaths. And we have had at least 9 countries in the last 21 days, in the last 1 week that have not reported cases for over 21 days, so which is good. So we are seeing cases in countries, but the transmission is not being amplified, which is good. Now, when we come so into the East and Southern Africa, only South Africa has confirmed cases. The 4th one was confirmed on Monday. And now we have 4 in South Africa. The 4th case was really linked to a traveler who had history of travel to Spain. So in the whole of the East and Southern Africa, the countries are at risk because we have DRC, of course, which is now a member of the East African community. We have Congo, which are also reporting cases. And then we have South Africa, which has imported cases. But the risk of transmission is there, though the countries in the East and Southern Africa sub-region are not yet reporting cases. So there is need for enhanced vigilance and scaling up capacities in these countries to be able to detect and respond. Next slide, please. So I'm sure people are going to ask about vaccination. So we know that the monkeypox virus shares the genetic structures with the smallpox, which was eradicated. So unfortunately, for some of the young people who did not get the monkeypox vaccine, they do not have any antibodies, because we know there's cross-reactivity between the smallpox vaccine and those that and exposure to monkeypox. So the current vaccines that we have are the second and third generation smallpox vaccines that have been developed. At least one of these vaccines has been approved for prevention of smallpox. However, this is not readily available. And so at this moment, we do not recommend mass vaccination, but targeted vaccination in the context of pre-exposure prophylaxis and post-exposure prophylaxis for contacts is recommended. So if you see in Africa now, despite us being the third in terms of the disease burden, we have not yet vaccinated any person in Africa. But we are working with countries to get ready, to prepare, to develop the necessary regulatory approvals in the event that the vaccines become available, they can be able to use for the high-risk groups and for the contacts. And also, engagements are ongoing with the manufacturers and some of the countries that have access to these vaccines, so that at least the high-risk groups and those who are contacts within Africa can also be vaccinated. But for now, we have not yet started the deployment of the vaccine on the continent. I think my last slide. Next slide, please. Christophe, my slide. Yes. So the key messages there. I think the first thing we have seen is that the disease spreads by contact, especially with an infectious person who has the rash. So when in any community or in any household, somebody has that type of rash, we should minimize contact with this person and try to refer the person to a treatment facility. That's very, very important. The second one, of course, is if the person has come in contact with any person who could be having rashes that are suggestive of monkeypox, is to wash the hands really, really well with soap and water and ensure then that this person, we have referred them. Another thing which is very, very important is that any person can get monkeypox. So we are all at risk of getting monkeypox. It's not selective, and every person is a potential case of monkeypox. And we have been saying this because the population now, apart from the few that I mentioned who could have gotten smallpox vaccine in the 80s when it stopped, and who could be having some level of protection, but the largest number of people globally now do not have any protection against this virus. So we are all susceptible. And if a person is sick in the household and has these rashes and already they are breaking and all these fluids are coming, the beddings that this person is using are highly infectious. So there is no need, they should not be sharing the beddings and utensils with sick people. Ideally, these people should be isolated. And if it is possible, have this person isolated in a health facility where they can be managed. For communities that hunt for food and all these wild animals, we always recommend that any wild meat or game meat that is being used for meals should be properly cooked. In this context, we usually have asked people to avoid, but we know that it is part of the diet in a number of communities. And so thoroughly cooking all animal products before eating is very, very important. For healthcare workers, the use of personal protective equipment while caring for patients cannot be overemphasized. And it's therefore very, very important that all countries make sure that healthcare workers have adequate PPEs to be able to care for their patients. the issue of avoiding contact with wild animals and those who are that are sick or found dead is very, very critical, especially when animals are found dead. These are animals that should not be eaten because you do not know what killed these animals. Could be a very, very contagious virus. Avoiding stigmatization. The way the disease presents, first of all, is very traumatic for the patients, for a person to see their skin like this. And the best we can do as community is to be supportive to them. And there is nothing, contact is contact. There is nothing about this disease that says that if somebody has it, it's because maybe they were engaged in some sexual activity or not. It's not exclusively spread through sexual activity, and it's not a sexually transmitted disease. It's something that is spread through contact. And that contact occurs in different kinds of settings. And so it is important then that we try to avoid stigmatization and we allow all people within the community who have symptoms of monkeypox to seek care. We should not deny any person access to care based on whatever kind of reason. People should be allowed to get care because we have seen the complications. They can be very, very debilitating and lifelong. And finally, we need to isolate infected people in homes or at health facilities and care for them and ensure that we avoid the complications that arise from monkeypox. So one of the things that I really would like to conclude with is that it's important for us as people who pass information to the population to emphasize that one, monkeypox is a disease which is not new. It has been there. It has just been amplified in terms of the transmission in recent weeks. And then the second one is that anybody is susceptible to monkeypox, and therefore we all need to take measures to protect ourselves. The third one is we need to avoid stigmatization and discrimination of people who present with any symptoms suggestive of monkeypox. And lastly, we need to ensure that we share the right information because it's the information that will empower the population to seek care and to be able to take measures to protect themselves and their families. So I think that was my last slide there. Yes, thank you.
Thank you very much, Dr. Ramadan, for that excellent briefing. Now I'd like to introduce my co-moderator, Ida Just. She's a Global Health Media Advisor with Intranews, and she's been monitoring the questions in the chat box that our participants have put in during Dr. Ramadan's talk. But and I think Ida might have a question of her own or two. So the floor is yours, Ida.
Thank you. Thanks, Wayne. Thank you so much, Dr. Ramadan. That was really enlightening. Of course, you mentioned stigma, and I wanted to say that some of the other speakers will certainly address how we as journalists can avoid stigma. So we'll leave that part for later. But we received a huge number of questions in advance of the dialogue and also in the chat, as you've seen. So I'm just going to highlight a few from the ones we've received in advance and to ask you. Mapur Malwal from South Sudan said there's a very common question in South Sudan. How do monkeypox and chickenpox differ? I'll maybe ask you three in a row. You did answer a lot of the questions. You did address a lot of the questions that came both in the chat and in advance. But there was another key question from Rachel James at UNICEF asking, how does monkeypox look different in this outbreak and in our region compared to the global outbreak? And then I'd like to also highlight one of the questions in the chat from Anne Ngengere. What have the epidemiological investigations shown to date? Has the virus mutated? Why are we seeing increased transmission in non-endemic countries and mostly in MSM, yet the disease is not classified as an STD? So thank you for those. So what's different in our region, the similarities with between monkeypox and chickenpox, and then this last question about why mostly in MSM. If you could please answer that for us, please.
Okay, thank you. Thank you very much for the questions. So let me start with my brother from South Sudan on the issue of the similarity or differences between monkeypox and chickenpox. Now, first of all, they are caused by different viruses. I do not want to go into that, but I think just for a person looking outside, trying to see how can we be able to differentiate this. So they both start with fever. That's something that's common to them. So monkeypox fever 1 to 3 days before the rash. Chickenpox also has fever 1 to 2 days before the rash. Now, the other thing, the difference is the rash appearance. Now, when you look at the monkeypox, the lesions often appear, they are all at the same stage. But when you look at chickenpox, you have the rashes appearing. There are those that are just coming up. There are those that are big, there are small ones. So you have a mixed picture. But for monkeypox, it's like they all appear at the same time and they are all at the same stage across the body of the person. Now, the next one is that the monkeypox rashes are slow when they are developing, changing, when they start from the small one before they are filled with fluids, when they are macules. So the development is rather slow. That's why it takes almost 2 to 4 weeks for it to clear. But for the chickenpox, it's very rapid. Now, the other critical thing is the distribution of the rashes. And this is very, very critical. You can differentiate. For monkeypox, the rashes are very dense on the face. They are also present on the palms and the soles of the feet. But for chickenpox, you don't have the rashes on the palms of the hands and the soles of the feet. So they are only on the trunk or the body of the person. So those are things that differentiate. The last one is that the person with monkeypox will have their swellings in the lymph nodes. I said the lymph nodes in the neck or in the armpits, they will be swollen. But that one, you don't find it in chickenpox. So those are the differences between the monkeypox and the chickenpox. But essentially, they all present with the rash. They all have fever, and the most important thing is usually to refer this person to a facility where a sample can be taken, and that can be able to differentiate which virus is causing this rash. In a country like South Sudan, you also tend to find measles, which happens more commonly in children under 5, and so which also presents with some rashes. So it's always good to have this child or this person tested to be able to differentiate. Now, in terms of what is the difference in epidemiology, now, like I mentioned, what we are seeing, first, our cases are not predominantly male, like it's happening in the other parts of the world. In the other, you can see that over 90% of the cases are male. Ours here, out of these 405 cases, we have 60% are male, 40% are female. And we also have considerable number of young people in terms of the population that are affected. So it's not predominantly male, that is the picture that we have. And then secondly, then you are seeing that the transmission, most of it happens in the context of households. And I was looking at reports, the colleagues from Congo here, it did investigation. They are following up on a number of cases. You'll find that one person picks up the exposure from an animal or somewhere. When they come, you will find that the contacts in the house, the wife, the children, and they will then become the subsequent cases. While you have seen in terms of the investigations happening in Europe and other places, you find people who have attended social gatherings in some kind of raves or parties and what, so the transmission happens in that kind of circle. But here it has been limited at the household level. So, we have not then seen evidence or reports of transmission related to sexual activity. That one we have not yet seen. Of course, we understand that in our region, the issue around sexuality is very, very sensitive, and most times people will not be forthcoming. So it's not something that we have seen, but the picture has not changed so much from what has been there before. Now, in terms of, there is still no evidence that the virus has evolved. I think there has been just the environment or transmission dynamics have been favorable. The virus probably was introduced in a context where there's a lot of interaction amongst people. And for any organism that passes person to person, the more contact you have, the higher the chances that the virus is going to pass to someone. Especially the cohort that we are looking at who are being affected are people in their 30s, their 20s, and these are people, like I mentioned earlier, do not have any protection from previous vaccination like the smallpox. So they are vulnerable people, and you introduce a new virus into a segment of population that has not been vaccinated. They don't have any prior immunity, and that allows for the amplification of this transmission. So that is something that we have seen. The last question was on, if you can remind me.
The last question had to do with the, in fact, actually, what was it? I think you answered all of the questions, actually.
Oh, okay.
I hope so. Monkeypox, and yes, I think you did answer them. I wanted to ask you, there are lots of questions about the science. Maybe ask one more question, and then we'll go to the next speaker. And hopefully, if there's time at the end, we can come to more of the questions. But, you know, you mentioned vaccines, and we followed with COVID-19, how our continent received them last. And you mentioned something in that regard. We are, as journalists, tracking that story as well. But what about treatment? I mean, given that monkeypox has been endemic in parts of our region, have there been treatments available? Is there something that our region, sort of tied to that, is there something that our region can teach the world now experiencing monkeypox for the first time?
Okay, thank you. So in terms of the therapeutics, unfortunately, then in our region, I think we have not been able to do a lot of clinical trials on therapeutics that, because we do not have much therapeutic candidate drugs that could have been used for study in this. Now you have seen that a number of, I was seeing yesterday, there are around 3 or so drugs that are being looked at for trial. And what WHO has done to try to even the ground is to develop a core protocol for therapeutics, which we want to bring all the countries together to be able to participate in that trial and use the 3 available drugs that are there to test. But previously, I think one of the things that we have excelled at is in terms of the the empirical management, the symptomatic management of these patients. In countries that we have had outbreaks before, you have not had very high fatalities happening because people have been managed just symptomatically and supportive care, and they have been able to recover. And one of the things is really trying to make sure that the infection prevention and control measures are very good around these patients so that you don't expose them to secondary bacterial infection and other superimposed infections that will kill them. So there has been very good experts in Nigeria, and so they have done so well in this, even the DRC, in managing these patients. So making sure they're isolated, making sure that the pain is taken care of, their fluid management is done very well so that they don't become dehydrated, and also that they don't become infected with other bacterial infections. So that is what they have done within the limited contact resources that they have, and they have done it so well, and we have had very limited deaths happening. But now that we have an opportunity to test some of these newer drugs, it's important then that Africa doesn't get left behind. And so that's what the reason for the core protocol that was developed, so that countries can also sign up and participate in these clinical trials, and we can be able to generate data that is relevant to the African context. The last one on the vaccines, I think it's also important to state that Africa should not get left behind. We have a few number of cases happening now, but we have healthcare workers who are frontline people who are always managing these patients, people in the lab testing, handling these samples. These are priority population that should be vaccinated. And I think the world should do the best and make sure these vaccines are available for these priority groups as well to be vaccinated.
Thank you. Thanks, Dr. Ramadan. Please stay on because there were so many questions around the science. We might get to them, and already there have been requests that we share your PowerPoint. So I hope that is okay with you, and we will then distribute it to everyone. Thank you. Back to you, Wayne.
Thank you both. Yes, and yes, for journalists who are trying to take frantic notes, we are recording this dialogue, and so we will be sending a link to you after the talk, so you'll be able to get your quotes of Dr. Ramadan exactly. Next, I would like to introduce Brian Kanyemba. Brian is a managing director and HIV prevention technical advisor with Advocacy for Prevention of HIV and AIDS. He has over 15 years experience in research, advocacy, and epidemiology. Drawing from the HIV experience and applying this to the unfolding spread of monkeypox, Brian will sketch how marginalization and stigmas are further deepened when one group happens to be mainly affected by a particular disease. Stigma due to sexual orientation plus stigma around disease often cause groups to go underground, meaning they don't even attempt to seek testing or healthcare. Brian, welcome to the dialogue.
Thank you, Wayne, and good afternoon, good morning, wherever you are. Thank you, Dr. Patrick, for setting the tone of these discussions. And indeed, my talk is going to be around stigma, and I wanted to literally, wanted me to put a video. Oh my God. Okay, let me see. I'm in cold Cape Town, so I am well. So I was saying, so my talk is going to be around stigma on what is being reported. I'm happy that Dr. Patrick painted the picture of what is in Africa, and specifically around the number of individuals who have got infected from January, and we've seen a number of 405, and we don't know if the infections, as he had said, were due to different sexual orientation or by sex, etc. But when we look onto the global scenario, what we are hearing is more of stigma around gay men and other men who have sex with men, whereby all the articles that we are reading now, there are more than 90% of new infections are specifically coming from gay men. Why I would want to talk a little bit about stigma. Let me give you a little bit brief history on diseases and gay men and other men who have sex with men. We still remember when AIDS started in the 80s, the articles that were there, that were available, practically what they were reporting on was the terminology that was being used then. For example, in 1981, the Center of Disease Control published an article on pneumonia, and it specifically said the people who were infected were gay men in Los Angeles. And again in that same year, another article was put out, and it was labeled gay cancer. And in 1983, again, a New York Times published another article, and the mention of that, the name that was given to that article was gay-related immune deficiency. So you can see the trend of how labeling started, especially in that period. And when you actually looked at the epidemiology of HIV, when we came to 1990, the numbers of people who are infected were not just generally, gay men and other men who have sex with men, which shows that now when journalists are putting towards or just someone who writes, because right now there's a lot of information that we are deciphering from from media, from social media, and from any other spaces. What is coming out now is the information that is coming out is very, very stigmatizing. I wish I was doing a presentation, but I didn't get time. There is an article, a cartoon that came out 3 days ago. I think it was New York Times or one of these international, showing what possibly gay men would have to show when they're traveling from one country to another. And very, very bizarre cartoon. And it came to my mind that really what is going on within the discussion of monkeypox transmission is literally not good at all. Dr. Patrick had discussed on the transmission of monkeypox. So learning again from HIV, he discussed a little bit about that monkeypox is caused by sexual contact or possibly by sort of touching. We don't know yet. So to specifically say, because when we are when gay men are in a community, are in a sauna and all that, this is the 100% transmission of monkeypox might be deemed not to be correct messages that would want to share with the public, because that is causing stigma too. Then another issue is monkeypox is not a big concern and only affect certain group of people, now, which is gay men and men who have other and men who have sex with other men. Again, this is not true representatives of the 37,000 people who have the conduct of monkeypox right now. If we disaggregate that number, there is a growing number of other individuals as well. So that number is possibly going to grow even big. I was just reading an article now that if one is continuously exposed to the virus, if one, they didn't even say who, that person can have monkeypox as well. So possibly we might need to work around that. And I know I've got a very, very little time. So again, possibly what would advise the journalists to look onto? There was a question on vaccine literacy. We really need to start advocating. Let's raise the positive picture of the monkeypox and really start to have these discussions with the countries in Africa. If we bring monkeypox as a gay disease, the governments of the African continent won't work around it. We've learned this from HIV epidemiology, especially onto the prevention scenario. This won't fly. So let's start to have this discussion again on communities themselves. We need to give the communities the real information. I was just thinking when Dr. Patrick was presenting that, I wish what he presented is what is being reported in the mainstream news. When the first case came out in South Africa, it was awash about dehumanizing gay men and other men who have sex with men. So as I'm ending, I think one good thing we need to know is anyone can be affected by monkeypox. The numbers are growing, and it includes other people as well, which are not gay men, others men who have sex with men. So yes, thank you. I'll end there.
Thank you so much, Brian. Ida, are there some questions for Brian or for Dr. Ramadan, or perhaps a question you might want to put forward at this point?
Thank you. Great. Thank you so much for that, Brian. We really take note. I do have a follow-up question for you, and it stems from a really good piece of social science research that has been done around this recent outbreak, and that is if monkeypox should have a special impact on the MSM population in Sub-Saharan Africa, if that should come about. We understand that hasn't come about yet. What would you then advise? Because it seems important to kind of balance the tension between useful information and stigmatization. We know that disease is stigmatized. We know that gay sex is stigmatized. We know that STIs are stigmatized. And of course, we understand this is not classified as an STI. But if there should be evidence of this population being differently affected from the general population, what would you then say to the media?
Thanks, Ida. I think I would not the right answer, but practically, I would really ask the media to report facts. One of the articles that I was reading earlier was talking about the disease and sharing about the manifestation and how it's transmitted. If that is reported adequately, that can help. And again, the social context of the usual messages that we are sharing when we are talking about STIs, STI transmission, when we are talking about HIV transmission, that is really related to gay men. That message should keep on being put out there that, yeah, this is possibly going to come. It might come really in Africa because we don't know these 3 people that are affected that have been recently affected, or those 405 people that have been affected in Africa. We don't know the modes of transmission actually. So we really need to speak or write about the specifics, the truth, but not labeling it as a, as a gay disease, as I was saying earlier when it comes to HIV. Over.
Thank you very much. Is there if there's anyone on the line who'd like to ask a question live of Brian, he really comes with so much experience, having examined how stigma plays out and how the media specifically also can play a role to counter that. Ask that now. Let's say maybe there's somebody with a burning question. If you do, please unmute yourself and ask Brian. Okay, not at the moment, it seems. I think then we can move on, Wayne, to the next speaker. Thanks so much again, Brian.
Thanks, Ida and Brian. Yeah, just if you're formulating your questions, please, you have lots of time to do that. And we'll move on to our next presenter, who will take us into some more issues on reporting on monkeypox. Michael Grissa, he's the editor of Health Times in Zimbabwe. He holds a certificate in public health communication from the Harare Institute of Public Health and a Bachelor of Sciences degree in Media and Society Studies from Midland State University. He's currently the Secretary General for the Health Communicators Forum in Zimbabwe. In his talk, Michael will remind us of how damaging misinformation was in the acute phases of the COVID pandemic, and how harmful ongoing negative stereotypes about HIV and MSM can be, robbing people of dignity and keeping them from care. Michael will reference the Introduce Monkeypox Toolkit, which is available now, which we will put in the chat box for journalists to access after. And he'll highlight a few pointers that resonate with him from the toolkit. Michael, welcome to the Media Dialogue.
Thank you, Wayne. Thank you so much for having me on this prestigious virtual dialogue. So while we wait for Chris to share the presentation, let me just start by saying thank you so much to Dr. Ramadan and Brian for setting the tone. You have really, touched on this issue, and I believe journalists were taking notes down, and from today going forward, we'll be reporting from an informed point of view. So my task is quite a simple one. I'm just here to present on what journalists need to know when reporting on the monkeypox, and why language and tone matter when reporting disease and key affected populations. Next slide, please. Right, you can skip that one because the doctor has already touched on the background of the monkeypox. Yeah, so basically, I will look at the reportage of monkeypox in the media. So you find that even though the world has experienced two global health issues within a space of 3 years, that is COVID-19 and the monkeypox, it appears the pathogens seem to be 10 steps ahead of us, and the media is playing catch up when it comes to reporting. So the media is playing rather a responsive rather than a proactive role when reporting on health threats, including the current monkeypox outbreaks. It has also been noted by public health experts that the language being used in the coverage of monkeypox has been stigmatizing and stereotyping against certain races and population groups. The language has also been alarmist and sensational. Yeah, so we can move to the next slide. Right. So let me just start by also giving a history of stigmatizing language in the reportage of public health issues. I'm glad Brian touched on the issue of how HIV and AIDS was stigmatized when it started. So I'm just going to give a brief background. So you find that every pandemic is a scapegoat. There's somebody to blame in each and every pandemic. So, like for example, here, according to the example that I got here, in 1980, there's this guy Ken Horn. He was a gay sex worker in San Francisco, California. He became the first person to be diagnosed with AIDS. By 1982, AIDS was now termed a gay-related immune deficiency. And this gained traction in the media. In 2020, during the COVID pandemic, when it started, you find that it was linked because it originated in China. So most of the reportage was linking the COVID-19 to China, and it was termed a Chinese virus. Even, former president of the United States, Donald Trump, actually labeled it a Chinese virus, and it raised a lot of stigma against Chinese nationals everywhere. I think there were videos that circulated on social media where you would see Chinese nationals being attacked physically because of such sensational and irresponsible reporting. So we move on to the current monkeypox that we have right now. Already you find that there's already a scapegoat in terms of the monkeypox. The LGBTIQ community already has been labeled, the population that is most at risk, and also Africans. You find that Africans are also being blamed for the monkeypox. So how is the media, transmitting these stereotypes? Next slide. Right. So in May 2022, the UNAIDS expressed concern that some public health reporting and commentary on monkeypox was using language and imagery, particularly portrayals of African people and LGBTI that reinforce homophobic and racist stereotypes and exacerbate stigma. You find that, the monkeypox was this year around May, I think, it was first reported in the UK. Global press, Western media, the CNN, whatnot, they were carrying images of African people with monkeypox, but by then we had not reported monkeypox here in Africa. So to a greater extent, that pushed, a racist stereotype against the African nationals. And it also, Ryan was saying, it's stigmatizing and stereotyping against the MSM and the LGBT community. The CNN, this example that I've given here, you can see that headline that already, even though they were quoting a health expert, but the language in the article was stigmatizing against a certain population group. Let's move to the next slide. Right, so what are the disadvantages of stigmatizing and stereotyping language when covering monkeypox? So you find that stigma and blame undermine trust and the capacity to respond effectively during outbreaks like this one, the one that we have, the monkeypox. And stigmatizing rhetoric can quickly disable evidence-based response by stoking cycles of fear. I think we saw that even in the during the COVID pandemic, that instead of people responding to the call to take up health services, fear was leading. It was actually fear that was reigning supreme at that current time. Like, people were not ready to take up services. We could go to hospitals, you couldn't get services because even healthcare workers were not ready to meet people just because of the fear that was instilled mainly by the media. And such language also drives away people from health services. And it also impedes efforts to identify cases and encourage ineffective punitive measures. You find that when you use stigmatizing language, people are not ready to come forward and present themselves at health facilities with certain conditions. Like, for example, during the COVID pandemic, people were not keen to come out open because of the stigma that was associated with the disease. So the same is happening right now because of the current stereotypes that are happening. People somehow they don't want to come out and say, you know what, I've got this case, I'm feeling these symptoms, they could be linked to monkeypox. but because now it's linked to the LGBTI, you know how it is viewed largely in Africa. Somebody would want to come out and say, this is what I'm feeling. And also such language encourages ineffective and punitive measures. I think you all remember what happened last year in 2021 when South Africa discovered the Omicron variant. You know, the world moved fast to, you know, shut Africa out. That's because the Omicron variant was reported here in Africa. So we need to be responsible in our reportage and coverage of pandemics, especially this ongoing monkeypox. Stigmatizing language can also create a false sense of safety, right, amongst those who are not, who do not belong to certain groups that will be labeled, you know, during these reportings. For example, you know, if you are not an African, you would say, well, why would I worry? This is a disease for Africans. If you don't belong to the LGBTI community, you say, well, this is a disease for gay men and LGBTI community, so it does not affect me. So such reportage services, the issue, it gives this false sense of safety, and people just believe that, you know, just because I'm not this, I'm safe from this disease. Next slide, please. So what are some of the steps being taken to reduce monkeypox-related stigma? So you find that the World Health Organization and global health experts recently convened a meeting where they agreed on new names for monkeypox variants as part of the ongoing efforts to align the names to the monkeypox disease, virus, and variants. So we find that previously we used to, the monkeypox variants were labeled according to their place of origin or country of origin or region of origin. For example, we used to have the Congo Basin variant, which is also known as the Central African variant. But now, under the new development, you find that the variants are now being labeled according to Roman numerals or clades. For example, the Congo Basin variant is now West African clade, or West African variant is now being called clade 2. The list goes on and on. So these are some of the measures that the World Health Organization have taken to actually reduce stigma-related reporting and stigma-related, messaging out there. Next slide. So what is the role of the media in public health? So at this juncture, it is critical to note that media are an essential arm of the public health system. Public health is the science of protecting and improving the health of people and their communities. To achieve this, there's need for promoting healthy lifestyles, researching diseases and injury prevention, and detecting, preventing, and responding to infectious diseases. So media thus play a promotional role in the public health system. Media also play an educative role by teaching people and the public health users the public health prevention as well as curative protocols to follow in the presence of a health pandemic. Next slide, please. So what is responsible coverage that is essential for reducing monkeypox stigma? Responsible coverage does not necessarily mean positive coverage or public relations. While the public health duty of journalists is to improve uptake of healthcare services, media should maintain their watchdog role and ensure health services reach the intended recipients. So when covering monkeypox, it is crucial to emphasize that the disease can be acquired by anyone, by all people, regardless of gender identity, or sexual orientation. I'm glad Dr. Ramadan and Brian also emphasized on that point that anyone can get monkeypox, and at the moment we do not have a vaccine for monkeypox here in Africa, so everybody is at risk. Next slide, please. So we find that the Center for Disease Control is also framing communication around the monkeypox virus. So below, these are some of the tips that journalists should consider when reporting on monkeypox. So rather than stoking fear, rather promote a messaging that provides information on what the monkeypox is and how it can spread, and also encourage seeking healthcare services if experiencing any monkeypox related symptoms. use reviewed nomenclature or names of the known and new monkeypox variants, like I indicated earlier on, that who now has new names or titles or labels for the variants. They are no longer being labeled according to their place of origin, like the Congo Basin, etc. They're now being labeled in terms of clades, like clade 1, clade 2, in Roman numeral terms. Also emphasize that anyone can get monkeypox and promote it as a public health concern for all. Focusing on cases among, for example, gay and bisexual men may inadvertently stigmatize the population and create a false sense of safety amongst those who are not in these groups. When using images of rash and from patients with monkeypox, focus on how cases typically appear in the current outbreak and avoid showing extreme cases unless necessary. In some institutions, such as healthcare provider education, it may be necessary to show extreme case presentation, carefully consider the audience and whether only presenting images of how cases typically appear may accomplish the goals. Also include pictures of people from diverse backgrounds and racial ethnic groups. So like I indicated earlier on, when the pandemic started, the monkeypox pandemic, the imagery that was there was that of Africans, even though we had not, recorded monkeypox in our region or in our countries. So that kind of imagery or reportage exacerbated the stigma and stereotypes against, the African population. Next slide, please. So in conclusion, it is critical to know that monkeypox is a zoonotic disease, and it is thus critical to note that almost all health pandemics being reported since 2020 are somehow linked to wildlife and wild animals. So it is therefore imperative to start paying attention to zoonotic diseases and increase coverage around the issues to keep news consumers informed on the need to avoid unnecessary human-wildlife interaction at all costs. When Dr. Ramadan presented earlier on, I think he gave us that diagram of a rat, then that the rodent moving, and then the person coming into contact with a human being, and then infection happening. And he also emphasized on the need to avoid touching or coming into close contact with animals, or touching even dead animals, because you don't know what could have killed that. So that's where the zoonotic part is coming in. So as journalists, this is probably time we emphasize on the need, for people to maintain or to stay away from unnecessary contact with wildlife and animals, because this is where most of our infections or most of our pandemics are coming from. So as journalists, you need to always stay in touch with your local epidemiologists and public health experts for updates around the issues. Yeah, so as journalists, if you're a health or a science journalist, it is difficult for you can't report these things from your own head. You need to keep in touch with experts, with scientists, so that at least you report factually and you do not report in a harmful way, but you report in a manner that helps the next person or the reader. I think next slide. I think there's a next slide at the end. Yes, thank you. That's my last slide. So I just want to say thank you. Tatenda Siabonga, asante sana. Back to you, Wayne.
Thank you so much, Michael. It's such an important point you make, that when a certain group is stigmatized when discussing any disease, not only is it unfair to that group, it also gives people outside that group this sense of security that they shouldn't have, that they feel safe that they cannot get the disease, which is absolutely not true. So I think that's one of the good points that you made during your talk. Ida, are there some questions we want to raise at this point?
I also want to say, Michael, thank you very much for those pointers on how to avoid stigma. And two things that you said felt to me like it is prompting me to ask another question of Dr. Ramadan, actually, because you mentioned stigma, and we know that the name itself, monkeypox, is stigmatizing. So Dr. Ramadan, we understand that as of yesterday, WHO has decided to actually turn to the public to actually perhaps even crowdsource suggestions on what the name change would be, because it's been more than 2 months now that WHO has been saying the name should change, but it's proven difficult. Why is that?
Thank you. So first of all, unlike COVID, which was relatively new when it came out, and it was new, it was easy for a name to be got for it. The monkeypox name has been there for, for a very long time. So it was there before the global best practices on naming of viruses were in place. So that is the challenge now. And it wouldn't be straightforward like for COVID-19 though it was to be able to come up with a name. So whatever name has to be picked, I think that has been the issue, that what name would be picked, because initially the name was given because the virus was isolated from monkeys that had been picked for study, but we have now discovered that the virus is not exclusively with monkeys, it's with so many other animals as well. So the committee that is responsible then for naming viruses is working on this. I think the first one, which was the easiest step, was to change the name of the clades, which the naming of the clades, which has been done. And then I don't know, the committee in its own wisdom, that the one that's responsible for naming the virus, decided to go with I think because it can also be a very polarizing issue. Whatever name you pick will always, people will interpret it from one dimension or the other. So I think to come up with a name which would be relatively acceptable to a broad section of the population, they have decided to crowdsource it and see if they can come up with something, as opposed to when people will sit with a few experts and come up with a name. It may never be, we will not have consensus from it, as opposed to when you have some kind of a consultation with the public to come up with a name that is, especially that will not have any stigmatization attached to it. So we hope that they can be able to come up with that soon, so that we can move away from the use of this name and begin to use the new name.
Thanks, so journalists, there's an opportunity to perhaps contribute to the new name.
Yes.
That would be great. I also, journalists need data. They need data. There've been a lot of questions about, how severe, how many people are affected, how many deaths have there been. I understand from one of the participants that Dr. Tedros himself recently said that there is a scarcity of data from Sub-Saharan Africa. Why is that? I mean, it's been endemic for so long. Why is there little data, and what did he mean by that?
Okay, so monkeypox was really one of those we would call the neglected conditions, like one of those neglected tropical conditions. And you find for a number of these conditions, the others have very good surveillance system and data available because there's resources allocated to conduct investigation and data collection. And as we know, these are things that are not very just less resource required. It's resource intensive to do that. Now, one of the things WHO did deliberately in 2019 is when we were doing revising the guideline for integrated disease surveillance for the African region, we included monkeypox as one of the reportable disease conditions that countries need to adapt. So countries started adapting in 2019 to include in their surveillance. So COVID interrupted that process of adapting the IDSR guidelines, but not every country did that. So some countries did. That was the initial step. Now, the second one, then one of the challenges you have with endemic conditions is always people say, this thing is always there. So they will not devote resources to go and investigate. So we have then agreed now to support countries to intensify the epidemiological investigation and collection of data around all the cases that we have. So we are working with countries, all the priority countries, especially those that have a slightly high burden of cases. WHO was able to provide resources for the country offices to support the response in those countries. So essentially what we want to do, most of the reporting has been in terms of aggregate data, number of cases. But now as this evolve, we need more detailed epidemiological investigation and widen the parameter, look at different variables, some of the things we are learning now. Try to see even in a sensitive manner, can we include something about the different potential exposures that can happen? So that's where now we are moving on. So ideally we have data in terms of numbers, but we don't have enough data in terms of what are the circumstances of the transmission. What are the risk factors? what are the determinants of disease severity, and all these things. So those are the things now that we want to do. And on the revised case reporting form that WHO shared, so countries are beginning to do that now. And we hope then we can begin to have more complete data for all the cases that we have, and it enables us to do analysis and answer the questions that people are having in terms of the epidemiological pattern that we are seeing in the region.
Great, thank you very much. Thanks.
Thank you.
Thank you. Earlier in this program, we showed you a video from Viral Facts Africa, the fact-checking and health experts who are part of the WHO's Africa Infodemic Response Alliance. And now we're happy to welcome Sergio Cicchini, who is the Infodemic Manager with the World Health Organization based in Nairobi and oversees the work of AIRA and Viral Facts Africa. Sergio is going to talk to us now about some of the really dangerous misconceptions about monkeypox that are currently circulating in the East and Southern Africa region. Sergio, welcome to the dialogues.
Thank you, Wayne, for inviting me, and thank you to Internews for assembling such a very significant level of participants and speakers for this media dialogue. The objective is to provide to the participant a quick overview about the main, let's say, narratives that we reported together with IRA members and partners since the first monkeypox cases were reported in European countries. Next slide, please. As we work together with a series of partners like UNICEF, the International Federation of Red Cross and Red Crescent Society, the Risk Communication and Community Engagement Collective Service, and others, with whom we shared our analysis about conversation occurring on public health events, both online but also at community level. So we are able to listen what's going on using different approaches and methodologies and also different tools. So since the first cases were reported in North European countries in May, we started to see on different channels sparkling conversations about the fears and anxiety that any new public health event can trigger. And some of them were already mentioned by the previous speakers, particularly the stigmatization and also a certain level of anger by seeing that pictures or visual reporting African people were used to complement the news that white people in Europe were infected by the monkeypox. And also starting to follow some already known and unfortunate disinformation pattern that we also saw for COVID, but also for public health events, like the fears that new restrictive measures or lockdown or quarantine practice may have been imposed by states to for, let's say, population control objectives, but as well other false claims that monkeypox was caused by COVID-19 vaccine side effects, as we have seen for other diseases. Next slide, please. Then ongoing narrative that we reported in most recent weeks is also quite common to other public health emergencies. First of all, the denial of the outbreak, or the accusation that the outbreaks has been artificially created, bringing false claims that external entities, could be Western governments or pharmaceutical companies, may have created a new virus for political or profit purposes. And again, a resurgence spike of disinformation around associating monkeypox as a consequence of the reduced immune system caused by COVID-19 vaccine, or something that we reported in Kenya in particular, that monkeypox could have been caused by the false claim that Kenya would have become a country where a new vaccine could have been used. And also very recently, and thanks to Dr. Otim that clarified that the fact that monkeypox is not affecting only men, which the stigmatization about targeting specific communities, LGBTIQ or MSM communities, we have seen that is having ups and downs in an online conversation. Next slide is a short overview about viral facts Africa materials that we have produced since we start to see monkeypox as a issues of concerns about health disinformation. The formats are very different. We started from debunking clear disinformation, explainers to reassure people about which are the facts that we know and which are the best practice, and also the history of monkeypox, or also interviews with experts. So far, we have produced several contents. All these contents that we have produced are accessible and usable in different in English and French. So we encourage media, agencies and NGOs to do not hesitate to share these materials that have been fact-checked by WHO experts. In the next slide, you can see the list of the materials and also the link to access. So thank you, Wayne. I stop here to ensure that there is still enough time for questions. Thank you very much.
Thanks so much, Sergio. We'll share those links for sure. Yeah, we do have a little bit more time, I think, for a couple of questions. Ida, are there some questions we want to share?
Thank you, Sergio. That was fascinating. Actually, earlier in the chat, there was a question from Mugwisage Brenda asking what HIV, COVID-19, and monkeypox have in common. And I think you've shown us that it has rumors in common for sure, or some of the perceptions are very similar. So could you take us a little bit through that, and what does that actually mean? It occurred to me that we actually have in monkeypox a moment to really, as journalists, to educate the public, to, we have a very important moment because there's been COVID fatigue, as we always hear, but there's a lot of interest in monkeypox now. So there's a moment to clarify some of the broader misperceptions that actually seem to arise no matter what the virus is. Could you address that a little for us, please?
Yeah, I think that it was mentioned earlier, the importance to invest on media literacy and also on misinformation literacy. So personally, I think that despite giving, let's say, correct news or even a knowledge that a certain level of uncertainty when we deal with new emerging public health emergencies, even if we know that people want to have clear-cutting answers, black and white and simplified content, sometimes it's also important to acknowledge that science has its own limits. And what we know today may be reversed in the coming future based on new evidence that science and epidemiology can bring on the table. But also, I think it's important to allow people to understand how misinformation, disinformation patterns work. Previous colleague Michael Shaw was mentioned the first case that was used to create stigmatization around HIV/AIDS in the early 80s in San Francisco. So now we know how misinformation, disinformation work. And I think it's important that we allow also people to understand how to detect misinformation, how to also talk to about some sensitive contents in their communities. We saw, for example, during the last part of 2021, how polarization around vax and no-vax people made it very hard for people to talk in a constructive way about COVID-19 vaccine, even amongst the same family group. The hate speech and the polarization of issue basically impeded people from talking and acknowledging this. So I think that, yeah, media not only reporting the facts as they are, which is something that is done, but also try to explain people how, for example, the stigmatization dynamics work, how in the history of public health emergencies, the stigmatization phenomenon also prevented key communities to get access to treatment or generated isolation that also limited the delivery of public health response.
Fascinating, absolutely. Thank you. I wonder if anybody on the call has wants to, raise their hand or ask or open their mic and ask a question. We still have all of our speakers here. Sergio, who knows about tracking rumors, Dr. Ramadan from the WHO. Sergio, of course, also from the WHO, but looking at the rumor tracking side, and then Michael Guarisa. He has a lot of experience since he is with the Humanitarian Information Facilitation Center in Zimbabwe, where journalists, focus on science all the time and look at what these viruses have in common. And of course, also Brian Kanyemba. Any more questions for any of them? Agan, please go ahead.
Yeah, thank you. Thank you, Ida, and thank you very much for the speakers as well. I heard one of the speakers saying that monkeypox is one of the neglected diseases. My understanding of neglected diseases is that there are those diseases that actually the people who suffer from them are also neglected. And then I also think there was a talk of One Health. I just want to, merge those two, and also just bring it to our attention that, and this I request from the speakers to bring to our attention that when we talk of neglected diseases, which other neglected diseases do we see or do we foresee that could soon be in the conversation and that we need to be quite, aware of or quite sensitive about. I want to thank the journalist who talked about the need for us to continuously engage with epidemiologists and health experts. My question to him would be, what have been some of them the nice things that you've heard when you work with the epidemiologists and also with other health experts? But then what have also been the pains? Those are the questions that I had for you, Ida and team. Thank you.
Thanks, great questions. Please go right ahead. Perhaps Dr. Ramadan on neglected diseases, and then Michael on the pains and pleasures.
Okay, thank you. And I want to thank Agan for raising that question. It's very, very important. So, and when I mentioned neglected tropical disease, I'm really trying to put that it's in quotes, but it's really in the context. If you look at monkeypox, and I'll talk about it shortly, it is being neglected because there's been no research in that area, no medicine developed, no vaccine available for the affected community since 1970. So we can rightly say that the populations have been, and in DRC, there have been cases year in, year out, but people have no access to that. But when we talk about the neglected tropical diseases generally by WHO, they are a group of over 20 conditions, and most of them are prevalent in our region, in the tropical region. So, for instance, there are many of them. There are others caused by fungi, others caused by parasites, by bacteria. But I would even be more worried about the viruses, for instance. And one of the things we're just discussing the last week with colleagues, for instance, when we look at dengue, for instance. We are beginning to see outbreaks. We have just been dealing with an outbreak in Sao Tome and Principe, which is just ending. When we see all these changes in the climatic conditions, the excessive flooding happening, and a lot of breeding sites coming for mosquitoes, and so some of these conditions are beginning to come up, and we should also be worried about them. For instance, as we see an increase in this population of mosquitoes, some of these transmissions can begin to happen. But when we talk about some of the other diseases. So dengue is one we need to look about. Chikungunya is another neglected tropical disease that we need to be worried about. And a number of others. There are 20, all of them. So that is a group that we need to look at. And in the same vein, monkeypox, though not listed among the neglected tropical diseases, but was also left out of the radar for a very long time. And we have been having an increasing incidence every year in terms when we have these outbreaks, you would have 200, 300 or so happening, but no research really being done and no vaccine being developed for the communities that are affected. So that's one. But I think the second issue that he brings, which is very important, is the One Health. And One Health refers to that interface between the animal, the human, and the environment. And all our diseases, most of 70 to 80% of the diseases we are dealing now with originate at that interface. And we need to strengthen that interface. A number of countries have started to strengthen that One Health coordination, but it's really not now at the operational level. For instance, we need to get to a point where our surveillance system does not only remain in health facilities, but we're also able to do surveillance in terms of identifying what are the commonly circulating viruses in the wild in our ecosystem. That way we can be able to predict epidemics and be able to develop tools in advance. Now we are at a point where every time we are firefighting, every time a new virus comes up, because we are not be able to predict, we start rushing around to get a new vaccine to try and get this. I think as we need to accept the fact that we will have new viruses emerging because the interactions between the human, the animal, and the environment is increasing. And therefore we have to purposely become more predictive in terms of how we develop our vaccines, our therapeutics, and we can be able to have a stock of these that are available to tackle some of the potentially circulating viruses that we have in our ecosystem. And I would think that we need to start thinking of dengue, we need to start thinking of chikungunya, if there will be the next viruses on our radar, for instance, and we begin to respond to that. Thank you.
Thank you. And I liked, I mean, it's a very important point that Agan also made about the people then also become neglected as a result. Yeah, sure. Thank you. I hope there's, you will stay on the line. Michael, there was a question for you about engaging with epidemiologists and other experts.
Okay. Yeah. Thank you again for the question. So from our perspective, I think as Zimbabwean health journalists, I constantly engaging with epidemiologists, science cafes that we host as the health communicators from Scientific. I think we managed to get access that was lacking from mainstream media. For example, during the COVID pandemic, would constantly engage these guys, and they would come sit down with us and issues in a manner that was easily understandable, and it would also aid us in our reportage of these issues. And I would say also by constantly engaging with the epidemiologists, it gives you as a journalist a front row seat when it comes to information, because information deficiency was a huge thing during the COVID pandemic events, monkeypox pandemic. But because these guys, they know these things, they've experienced them for a long time. When you sit down with them, they can give you this information. It will be easy for you to report on various science and health issues. So you also asked, what are some of the disadvantages? Well, yeah, scientific issues are a bit complex. For example, writing RNA or RNA in a language that can be understood from an old lady or from a person from the street, it's a bit complicated. So I would say there is need somehow to get down language, scientific language, in a manner that can be understood by health journalists, so that they can also cascade the information down to the information. Yeah, that would be my response.
Thank you so much. And I'll just briefly mention, I know we've come to the end, that Christoph has posted in the chat a resource, which is also very useful for journalists and talks about many of the same things that Michael spoke about. It is part of our when I say our series at Internews, a One Health series. It's quite extensive. There are lots of tips in there. Many of the things mentioned, both the science mentioned by Dr. Ramadan, the danger of rumors as mentioned by Sergio, and the role of journalists and the importance of not stigmatizing those with monkeypox. All of those issues are actually encapsulated in this toolkit, which is in the chat and which Christoph will also email to you afterwards. Thank you.
Thanks, Ida. Yeah, and as we prepare to wrap up another media dialogue, I'll let you know that we will be sending a recording of the dialogue to everybody on this call. We'll also send the link to the monkeypox, to that One Health toolkit that Ida was just talking about. And we're also going to send audio excerpts of our keynote speakers to our network of journalists via WhatsApp. And as always, of course, we'd like to hear from you. How useful has this been? How can we do this better or differently? What other topics would you like us to handle in the media dialogues? Please give us your feedback, because that's how we make this series better. Many thanks to Dr. Otim Ramadan, Brian Kanyemba, Michael Grissa, and Sergio Cicchini for joining us today for this really interesting discussion. And until next time, for Ida Just and the RCCE Media Working Group, I'm Wayne Sharp saying thanks for joining us, and stay safe. Bye-bye.
Thank you. Bye-bye.